effective. Dr. Islam.
Thank you, Professor Adel Nabi, Dr. Ahmed Al Hussein. Hello again, dear guests and colleagues. I think most of you have an important questions in the back of your mind, especially those who don't have a powerful laser machine at their institute. Is the laser machine worth its cost? Is it cost effective? It's worth the money spent in it? This talk is determined to answer this question. This map is according to the United Nations. It shows developed countries in green and the developing countries in orange and the least developed in red. I think most of the attendees right now are in developing countries. Like we are in Egypt, we are here in orange. Our fellows or our colleagues from Saudi Arabia, Iraq and Jordan all in orange. Our colleagues here from Cameroon, Dr. Abdel Wahab is here in orange, right? And Rwanda, small country at the center of Africa here, also in orange. I double checked it yesterday. So most of the attendees in orange. We are all in developing countries. So back to our question, is HOLIP effective in developing countries where we lack resources? HOLIP has been described by Peter Gelling in 1998. Since then, numerous publications have reported its safety, efficacy, and durability, but the cost efficiency is the remaining concern. Despite the encouraging data about the technique, some authors claimed that laser prostate procedures are superfluous in the management of BPH, like this article. And when we search for the word superfluous in the dictionary, it means unnecessary or غير ضروري in developing countries. So, in order to solve this problem, to answer this question, the study was done at our center 2 years after purchasing the laser machine. HOLIP procedures performed during the 2 years were compared to open prostatectomy to analyze the cost efficacy of both procedures. Matched pair analysis was performed using resected prostate tissue weight as a sole matching criterion. Based on that, 92 cases of HOLIP versus 91 cases of open prostatectomy were compared, and the mean resected prostate weight in both techniques was around 100 grams. So what was the result of that study? Firstly, the median time to catheter removal and hospital stay. It was 2 days after HOLIP, and it was 5 days and 9 days respectively after open prostatectomy. Of course, the prolonged hospital stay and catheter time will reflect more cost eventually. Regarding the efficacy parameters, this graph shows the efficacy parameters reported after 1 year follow-up. It showed comparable efficacy between HOLIP and open prostatectomy, with slightly HOLIP is slightly better regarding the IBSS score, the Qmax, and less PVR. Regarding the post-operative reduction in PSA, which represents a marker of the amount of prostatic tissue removed, it appears to be better in HOLIP. It reached as high as 80% reduction of PSA after HOLIP, after 1 year. Regarding the post-operative complications, after HOLIP, one patient was readmitted for bulbar urethral stricture, right here. And regarding the open prostatectomy, one patient was readmitted for urethral stricture and one patient was readmitted for bladder neck closure, which needed revision in the urologic procedure. Regarding the stress urinary incontinence, it was mild, grade 1. It appeared in 3 cases of HOLIP versus 1 case of open prostatectomy. All of them didn't need revision anti-incontinence procedures. It was managed conservatively. And lastly, the perioperative bleeding that required blood transfusion, it was significantly higher in open prostatectomy group. And finally, and most importantly, the procedure cost analysis. To do this, all costs were calculated since we purchased the laser machine, and we divided them by the total number of cases that were performed, and we came to an estimate for each cost of each single procedure. All expenses were calculated in detail, like the laser machine, the morcellator machine, reusable laser fibers, and morcellators, and perioperative irrigation. All of these were related to the HOLIP procedure, not applicable in open prostatectomy, of course. And if we look at the hospital stay, it was significantly higher in open prostatectomy. And the sum of this, there were comparable total costs between both procedures. So after 2 years of purchasing the laser machine, from 2012 to October 2014, HOLIP procedures costs the hospital 4,100 Egyptian pounds versus 4,300 Egyptian pounds for open prostatectomy. Back then, 4,000 Egyptian pounds were equal to $500. Of course, not the case today. So, to answer the question again, is HOLIP a realistic alternative in developing countries? We concluded that in high volume hospitals, HOLIP procedures seem to be equally safe and effective to open prostatectomy, with the advantage of minimally invasive procedure, of course. 2 years after adopting the technique, HOLIP equally costs the hospital as open prostatectomy, and significant hospital cost savings are anticipated in subsequent cases, because in endourology, there is always a capital investment in a new technology, and with time and with more number of cases, this capital will be negligible. This is another study. It was done in Mayo Clinic in 2023 to evaluate the cost effectiveness of different surgical treatment options for BPH. A cost utility analysis was performed comparing HOLIP to bipolar TURP and water vapor thermal therapy like Rhizome and prostatic urethral lift for prostate size less than 80 grams. It compared HOLIP to simple prostatectomy for prostate size more than 80 grams, and the primary outcomes included Medicare costs, cost effectiveness ratio, and quality adjusted life years. So, regarding the results of the study, HOLIP cost less than bipolar TURP and prostatic urethral lift, and it had the best quality of life score among all procedures. So this translated that HOLIP is the most cost effective of all. This is for prostate size less than 80. Okay, if we talk about prostate size more than 80 grams, HOLIP was also better in cost, less cost than simple prostatectomy, and better quality adjusted life years, and this also translated that HOLIP being the most cost effective. So they concluded that after 5 years follow-up, HOLIP is a cost-effective surgical treatment for PBH independent of gland size. This is another study. It's done in Ain Shams University. It was done to compare HOLIP to bipolar enucleation of the prostate. And they found that HOLIP procedures had significantly less operative time and catheter time and hospital stay. Of course, this will translate to less cost. And for cost analysis, for each procedure, they calculated the laser fiber or bipolar loop, they calculated the irrigation fluid, calculated the hospital stay, and surprisingly, the total was less for HOLIP procedure, about 3,000 for each case versus 4,500 for each case of bipolar TURP. There is drawbacks to this study, of course. They did not calculate the laser machine price and divided by the cases. They assigned one loop of bipolar TURP for each case of enucleation. whereas they assigned 1 laser fiber for each 10 cases of HOLEP. And they concluded that both HOLEP and bipolar enucleation of the prostate are safe and effective in management of large prostatic adenomas. HOLEP had shorter operative time, hospital stay, and earlier catheter removal, and it was more cost effective than bipolar enucleation. There are 2 more studies to optimize the cost efficacy during HOLEP. They were done at our center. This study assessed 2 different types of morcellator, the old VersaCut morcellator and the new family of morcellator like the Piranha and other rotating morcellators. And it found that the new family of oscillating morcellator like the Piranha was significantly better. It had better tissue retrieval, 6 gram per minute versus 2 gram for VersaCut family. It had more number of procedures performed per blade, 22 versus 18, and more prostate retrieved per blade. And the last study was done to compare low power to high power laser HOLEP at our center. And it concluded that low power HOLEP was shown to be comparable to high power HOLEP in terms of all efficiency parameter, regardless of the level of surgeon experience. So as a take-home message, we can say HOLEP can save money, replacing the superior super invasive open simple prostatectomy. Laser is no more superfluous in modern urology. It can be used in different fields like laser stone surgery, laser en bloc resection of bladder tumors, laser management of urethral and ureteric strictures, and of course HOLEP. And HOLEP also can save money by optimization of its technique by using low to moderate power laser and using the new family of oscillating blades and reuse the blades to save money in your pockets. Thank you.
Thank you, Dr. Islam. Can we consider HOLEP as a gold standard?
Yes, I consider HOLEP as a gold standard, especially for larger prostates. Larger prostate, more than 120, 150.
What are the definition of gold standard?
So I think this is a very good question. What is the gold standard in our life? The term gold standard was initially described when they started to use dollar, US dollar. And at that time, they were keeping gold in relation to each single US dollar printed. And later on, when they start to separate the price of the dollar against gold reserve in the US stocks, they start to have the economic crisis. We have, everything is going down because it's just papers are printed. In surgery, we used to say that the gold standard is the technique that would survive the test of time. So it's there for years, and now we have HOLEP since 1998. And we have many techniques for prostate that appeared and disappeared throughout this 27 years since we have the HOLEP. Number 2, it should be widely available. And previously, HOLEP was not widely available, but now HOLEP is done everywhere. Number 3, it should prove efficacy, safety, and durability. And now we have a very good, solid data supports safety, efficacy, and durability. So now we can say that HOLEP is a gold standard.
Okay. What about the availability in developing countries? This is the last point.
Yeah, it's widely available now. I would say here in Mansoura, it's available in private hospitals and as well as in university. And we have been working for the past 15 years to develop this service in different centers in Egypt and outside Egypt, even in the Arab countries as well. And we, more or less, we succeeded in that, but let us say it in a different word. We need a dedication. HOLEP is a very good surgery, very unique surgery, perfect outcomes, but yet it's difficult to learn. So it needs some sort of dedication. I ask every one of you to keep the next 6 months to strive to optimize his capabilities and his skills in this surgery. And I would swear that he will never regret that he spent time. You have to leave something to get something. You have to leave. I'm not going to do more laparoscopy. I will focus on own HOLIP. I will spend more time. I will accept that the anesthesia team would come to say to me, let's finish. We need to give more cases because you spend more time in every single case. This is life. When you go back to surgery, the life, you start your first PCNL to do it, 2 hours, 3 hours. You would strive to do the puncture. Everything in surgery would be like that. But if you stopped easily and you frustrated from failing to optimize the first few cases, don't expect to do your first cases like that in life surgery. You have to work and work. And I promise, in 6 months, you will have the service in your hospital. And that we can say that this is our new gold standard.
Okay, so we have two limitations. First, the availability in the developing countries. Second is the surgeon training. Okay?
That's right. So actually we studied that the low power HOLIP could be done down to 50 watt. So I would advise having a moderate size, moderate power holmium laser machine to start with. Because actually, if you start with a 30 watt, it will be very tough. And frequently, you will not be able to achieve the minimum frequency that you need to achieve the micro dissection. So maybe the 3 watt is not bad, but the problem is the very low frequency range. Because if you ask me, what do you need more in holmium laser energy? Is it the joules or the hertz? I need more hertz, because you need more hertz to create more bubbles, to create more micro dissection. So you need more hertz. So the minimum is 50 watt laser machine to achieve at least 25 to 30 hertz. So did you attend yesterday case discussions? We have up to 800 grams. So it's actually size independent, but I don't ask you to do 500 grams in the next 1 year. So you need many cases to be done before going for that size. Dr. Adel, we can go for last lecture in this session.
The last lecture is how and when to start inoculation of the prostate by Dr. Ahmed Al-Kaffaz.
Thank you, Professor Adel Nabi. Thank you, Professor Ahmed Shel. Good morning again. Today I'm going to speak about how and when to start inoculation of the prostate. When to start? Just start now. If you decide I don't have a laser, start now. I don't have a working element, just start now. Even if I don't have morcellator, you have to start now. So my advice to you to start now by watching videos, watch real cases, by an expert in the OR, that what we are doing now, set up the instruments, watch the hand movement, watch non-edited troubleshooting. So inoculators never go back. You have to, in this video, how to go and start inoculation with a lack of resources. Just inspect the prostate. It looks a moderate large prostate. Here there is a cleft. You can push gently to gain the plane between the adenoma and the capsule. Here, just elevate the adenoma, and then you can incise the attachment between the adenoma and the capsule. Even if you don't have laser, you can use the bipolar. If you have different types of loops, either modified inoculated loop, laminar loop, as we discussed before, or Herman loop, or even by regular resection loop. You can just gentle push of the prostate, of the adenoma, and incise the attachment, and you get the plane. You can choose your index prostate. Choose the starting size is between 50 or 60 to 100 gram. In this case, now we will start to resect the prostate after gaining the good plane. Resection in this case there is
عايز تطلع البوينتر؟
خلاص مش هيطلع عشان البتاع. ماشي. In this case, just resection after getting the plane. You can also start with this in the first few cases, and then the following cases you can complete enucleation even with mushroom technique, and keep the adenoma attached to the bladder neck from the side between 3 and 5 o'clock, or and in the right lobe and then the left lobe from the side between 7 and 9 o'clock, and then start to resect. And if you have a morcellator after that, and or you want to go for mini laparotomy, you can complete the enucleation as we did in our live surgery today. Here we have a bleeder, and the bleeder, if you didn't get access to it, you have to resect the tissue in front of it, and then coagulate the bleeder. You have to check the sphincter ring from time to time. You have to remove the chips, evacuate the chips, and evaluate your fossa here. You evaluate your sphincter ring, then evaluate the fossa, evaluate the hemostasis. And that's it. Start first few cases having a proctor, which is virtual support. Start medial lobe enucleation alone, and start your own case using the ABC approach as we said before. Design your track. Select your early case, what we call index cases. No coagulopathy, de novo, low anesthesia risk. The prostate size optimum to start with is between 60 to 100 mil. Below 50 or 60, the plane will be difficult because it's fibrous, and above it, maybe because between 60 and 100, if you cannot complete the enucleation, you have to go with resection, and it will be easy and not frustrating you. The case volume dense, it must be between 1 to 2 cases per week, and you have a supporting team in the OR with no rush. You have to re-watch real cases by an expert in the OR for fine-tuning, and finally, you have to run alone. It's always good to revisit your outcome. You have to record your cases and follow up your case. Record your case, report the outcome, both objectively and subjectively, then recheck the recording and correlate with outcome. You will be expert only when you proctor. Start early to proctor your colleagues. Thank you.
So, Dr. Ahmed, thank you. You designed a very nice track. I advise all of you to follow this track. So, you will go back home in few days. You have a booking for a case for monopolar TURB. Just monopolar TURB. Please, don't resect as usual as you was doing before. Start to enucleate. What is the advantage? Number one, to fix the steps that you already got. Number two, you will definitely do a better resection. Why? The partially enucleated adenoma is less vascular, so less bleeding. What is the bad things about TURB? Bad things about TURB is that you violate the capsule. Now you see the capsule from point 0. What's the bad about TURB? That you may endanger the sphincter. You see the sphincter from point 0. So definitely you will optimize the outcome of regular TURB. Meanwhile, you optimize your learning curve. And it's always important to revisit what we have seen here today and yesterday, and keep doing enucleation. Never go back. Never do the previous resection. So today, I'm always doing enucleation in even small cases where I am going to complete by resection. Do enucleation. It will optimize the outcome of your resection. So if you have any questions, yes.
ايوه
So as we
أيوة،
saw in
دكتور
the
عادل.
video, we need to inoculate and start to cut stepwise. You know the Nesbit technique of resection? They start in circles
حالة ايه؟
from the bladder neck, mid fossa, and then the apex. So partially inoculate and then go inside the bladder. Start to resect in a circle and then go to the mid fossa.
طيب.
Start to resect in a circle and then go back to the apical port. And in that way, you get the best benefit. This is not a mushroom technique. This is what I'm saying. It's a mushroom technique that you have to inoculate the adenoma completely, do the apical separation, and complete inoculation anteriorly and laterally, and keep it attached at 3 to 5 o'clock position. This is totally different. And actually, I don't like the mushroom technique because it's hustle and it will keep time running. So I advise you to start like that. And if you have a moderate sized prostate and you would like to do a mushroom technique, stop inoculation from underneath. So apical inoculation, rotation, finish the anterior inoculation, and keep it attached throughout the prostatic lens. In that way, you have it fixed, and you can keep resecting it without having large chunks drop to the bladder. Because the problem, if you have a large chunk of tissue dropped into the bladder, you have to keep running after it to resect a freely floating adenoma, which is a hill. So you have two options: to partially inoculate, to have the landmarks. That's only, and to have the pleasure and the orgasm of developing the plane of inoculation. Every time you do it, you will feel happy because your resection definitely is far better. Because you know where is the capsule, where is the sphincter, and the adenoma is a bit less vascular, especially during the apical resection. What's difficult about URB is the apical resection. What's the main difference between expert resectionist and the regular resectionist? The apical resection. The expert will clean the apex properly. Now you will do as an expert by knowing how to clean the apex. So we can go for the coffee break for 15 minutes and start the second session. والله هم عشان قلبوا جنرال. خلاص ماشي هنقعد كوفي بريك، ممكن ادي محاضرة. ماشي.
هو الناس اللي ما رضاش يجي ولا ايه؟
ماشي انا دخلت له المكتب وقفلت عليه. قلت له علاقته بالخدمة. يمين شمال مفيش. صعبة بصراحة.